حبيت أشكر الجمعية الأردنية للدعوة لهذا المؤتمر المتميز، وعلى رأسهم الدكتورة وفاء، وأنا كتير سعيدة بوجودي في هذا المؤتمر، ومستوى كتير العلمي عالي ما شاء الله. يعني اللجنة العلمية مشكورة والتنظيم ممتاز ما شاء الله. So I will introduce the next speaker, which is Dr. Fatima Alnaimat. She graduated with an MBBS degree from University of Jordan. She completed internal medicine residency training and rheumatology fellowship training at the University of Arizona, USA. She is diplomat of the American Board of Internal Medicine and the American Board of Rheumatology. She is a former full-time rheumatologist at the Essentia Health, Minnesota, USA, and she is assistant professor of medicine and rheumatology at the University of Jordan. She is also vice president of the Jordanian Society of Rheumatology. So Dr. Fatima will present from cohort to care, tracking 2 decades of scleroderma characteristic and ILD management in Jordan. So Dr. Fatima, the stage is yours.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Thank you very much for your introduction. Okay. Bismillah. Our talk today will be talking about systemic sclerosis, ILD, in Jordan. So I'm going to go over a view of systemic sclerosis and systemic sclerosis interstitial lung disease, and then to address the question and answer the question, why to study systemic sclerosis, ILD, in Jordan, and go over our research project that we did in this regard. So when we think about systemic sclerosis, we think about fibrosis. So it's a chronic autoimmune disease with a hallmark of fibrosis and vasculopathy. Fibrosis occurs in different organs, leading to progressive scarring in different organs, particularly the lungs, the skin, joints, esophagus, and other organs. Vasculopathy is also a hallmark of the disease, which manifests mostly with Raynaud's phenomenon, which may usually present early in the disease course. Immune dysfunction results in the production of autoantibodies that we can see in those patients. How common is this disease? As you all know, it's not common, so the global prevalence of systemic sclerosis can reach up to 20 cases per 100 million worldwide. So, as we all know, there are 2 phenotypes with the systemic sclerosis. We have the diffuse and we have the limited phenotype, and both are distinct by the extent of the skin sclerosis. In the diffuse form, it's usually involved the trunk and the extremities, whereas in the limited phenotype, the skin involvement is limited to the distal extremities plus minus the face. The interstitial lung disease is a particular risk in the diffuse form and less so in the limited form. The antibodies, we know the diffuse form is linked to the anti-topoisomerase antibody or the anti-SCL70, whereas the limited type is linked to the anti-centromere antibody. High-resolution CT scan is the golden standard method to diagnose interstitial lung diseases. And what do we expect to see in patients with systemic sclerosis or all types of ILD is ground glass opacification, fibrosis manifestations. So how prevalent is interstitial lung disease in systemic sclerosis patients? Variable reports, but it can reach up to 70% of the cases. So it's really not uncommon. It's really common in our patients. The manifestation that we can see on the radiological interpretation includes most commonly non-specific interstitial pneumonia or NSIP, which usually manifests with ground glass opacifications and bronchiectasis. Less so, we can see the fibrosis types, the UIP pattern, where you can see a lot of honeycombing and distorted architecture and cystic changes. So with the clinical significance of interstitial lung disease in systemic sclerosis, it's a leading cause of mortality. So it's really important to pay attention to this very important risk for mortality in our patients. And the problem with ILD in systemic sclerosis is the unpredictable course, because some patients and many patients are asymptomatic despite the presence of fibrosis on their imaging. And at the same time, some patients progress fast, some patients don't progress. We cannot tell who will progress. So it's really important to keep an eye on those patients with regular monitoring to catch early progressing patients. So why to study ILD systemic sclerosis in patients in Jordan? Because there is a gap in the literature. We don't have a lot of information and data from the region in the Arab world and in Jordan in particular about systemic sclerosis and about systemic sclerosis ILD. And it's known that there is epidemiological diversity. There is heterogeneity in the literature regarding the characteristics and the outcomes of different populations in regard to ILD and systemic sclerosis. So to fill this gap is something important, and this will ultimately lead to improvement in the patient care regionally to improve regional clinical practice guidelines. There has some data from the region, from Arabic countries. We have data from Qatar, Tunis, Iraq, and Egypt about systemic sclerosis, but mostly talk about the characteristics. I found this registry from the United Arab Emirates published 2 years ago to talk about, in general, the characteristics of systemic sclerosis, but also talk about ILD patient. So what they found among 167 systemic sclerosis patients from diverse ethnic backgrounds, these not only Arabs, because you know the Emirate, they have diverse ethnic population. They found 54% of the scleroderma patients have diffuse form, and among them 63% had ILD. This is really a significant percentage. And 45% had limited cutaneous sclerosis, and among them 40% had the ILD. So our study, when we thought about this research, we thought about to study systemic sclerosis in Jordan, to study ILD patients, to look at their demographic features, their imaging characteristics, and management outcomes. The study design, it was a retrospective observational study performed at the Jordan University Hospital. And as you know or may not know, Jordan University Hospital is the oldest and the first teaching hospital for the School of Medicine in Jordan. And it's a large tertiary center, and the study was done in the rheumatology outpatient clinic. We collected patients who came for scleroderma care in the rheumatology outpatient clinic over 25 years. So the collection of data started in 1998, and we collected patients all the way up to 2023. So patients were divided into old cohort and new cohort. The old cohort were patients were collected early from like the 1990s and early 2000, but they lost follow-up or stopped coming until 2019. And patients who were actively still following in the clinic, where we can see them, these were called the new cohort. This study was not designed to be a prevalent study. It was designed to study the cohort of systemic sclerosis patients who came for care in our clinics, particularly their ILD status, to see if they are suffering from ILD or not. So the inclusion criteria for our study, patients should be adults above the age of 18, and they should have high-resolution CT scan findings. So even if we have systemic sclerosis patients, if they don't have any available HRCT, they were excluded. Patients also were excluded if they are overlap or if they are no available reports, of course. The study collection, as we said, was extensive over 25 years duration. We collected patient demographics, surgical profiles. We looked at their pulmonary assessment, their PFTs, their diffusion capacity, and also the HRCT report. We looked at their treatment, management, and mortality. So what did we find? We collected 129 patients over this long duration of follow-up, 90% of them females. As expected, these are female predominant patients. 55% were limited phenotype, and 44% were the diffuse form. The age at onset was consistent with the literature, around 40 years of age, that's the age of onset. There was a mean diagnostic delay of almost 3 years for those patients. The antibodies, 75% were ANA positive, 25% for SCL70, and anti-centromere in 22% of the patients. The prevalence of ILD, as reported on HRCT, was 59% of the sample of the patients. If we study them based on phenotype, patients who have the diffuse type, 77% of them had the ILD, whereas limited phenotype, 44% of them had ILD. As per other characteristics, esophageal involvement in almost 60%, and 27% had pulmonary hypertension. So the findings on HRCT for the patients. We diagnosed ILD based on HRCT as per radiologist report because we have a radiologist on board who looked at the images and scored this for ILD based on the presence of fibrotic bands, bronchiectasis, ground glass opacification, and honeycombing. The spectrum of findings included fibrotic bands in 34% of the patients, ground glass opacification 26%, honeycombing, bronchiectasis, lung nodules, and pleural thickening, as you can see on the figure. If we compare the old versus the new, why we wanted to compare? Because this study looked at the trends. We wanted to see if we improved actually our management, if we are following guidelines, if we are changing in our practice. So we found that actually on average, patient underwent the high-resolution scan 6.9 years after being diagnosed. So this is really a very long duration, and I think we will hear more and know more from the following lectures about the screening and management of ILD in systemic sclerosis and other connective tissue disease. Screening is important. We have to screen early. So we can see that patients actually were screened by HRCT somehow late in their disease history. That's why we see significant findings, like the percentage of fibrotic bands. This is 40% in the old cohort, 27% in the new cohort. Ground glass opacification, 16% in the old, 37% in the new. Honeycombing, 9.9 versus 29 in the new, and bronchiectasis, 4% in the old versus 31 in the new. As per pulmonary function test, as expected, they were significantly associated with interstitial lung disease. There was drop in the DLCO, FV1, and FVC. The FV1 over FVC ratio was increased, consistent with a restrictive lung disease. That is manifestation of fibrosis. We looked at the predictors for interstitial lung disease. What are the factors that can tell that the patients might be going to ILD? This was statistically done through the multivariate risk model following a logistic regression model with adjustment of the age and gender and disease duration. The key findings for our patients that diffuse disease is the strongest predictor of ILD, in addition to the decrease in DLCO, because each 1% reduction in DLCO increased the risk of ILD by 3%, and also the presence of pulmonary arterial hypertension and the NTSL70 positivity. So in our data, predictors of ILD included diffuse type, pulmonary arterial hypertension, the presence of NTSL70, and the reduced DLCO. How about management? What do those patients receive? Chronic steroid was almost 50% of the patients were on chronic steroid. This is for ILD and non-ILD. In general, the cohort management. Mycophenolate was 38%, nintedanib in 11.5%, rituximab in 5.3%. In terms of trends, what did we do before and what are we doing right now? For steroid, almost the same. Patients, old cohort versus new cohort, almost the same percentage. But look at mycophenolate. Mycophenolate in the old cohort, only 18%. In the current cohort, 58%. And that actually speaks for itself because this is the guidelines. Patients should be on mycophenolate to treat the inflammatory component of their ILD. Nintedanib, 11.5%, 3.4% from the old cohort, and 19% from the new cohort. I think those old cohort were patients, 2 patients who were lost follow-up and re-established and got started on nintedanib later on. Rituximab utilization was the same, 5.3%, almost the same between the old and the new cohort. Cyclophosphamide exclusively in the old cohort. We're not using it as much right now in our current scleroderma patients. Combination therapy was there. Patients were either on combination steroid or mycophenolate, steroids and cyclophosphamide, mycophenolate with cyclophosphamide. These are old, of course, data, plus nintedanib as add-on therapy for the progressive fibrosing phenotype. How about morbidity and mortality? Morbidity, we can measure it through hospital utilization patterns. So the mean hospital admissions for the patients were 5.8 admission per patient. There was no significant difference between ILD patient and non-ILD patient in the total admissions. However, patients with ILD, of course, had more respiratory admission causes. So patients with ILD got admitted more due to respiratory causes. In terms of mortality, 15 deaths occurred through the follow-up period, which account to 11.6%, and the 80% of the diseased patients were all ILD patients. So respiratory causes accounted for 40% of the mortality, followed by infections, but the vast majority of who died actually were ILD patients. So what this carries to us? What are the implications for this, from this study? Respiratory causes cause 40% of all deaths. Overall mortality, 11.6%. 60% of our cohort ILD patient. This is really important because you're talking about patients who are female, mean age of diagnosis 40 years. So these are productive patients who actually lost years because of this disease. So this highlights the importance of early detection and combined approach between screening and early treatment. I'm not going to go over the treatment because I think it will be covered in later talks, but patients should be screened and should be managed accordingly. Screening in scleroderma is frequent, more than the others, connective tissue diseases, ILD. Patients should be satisfied according to their risk. ILD patients in scleroderma, these are high risk, so they should be screened and managed accordingly. Treatment per guidelines, as we can see, similar to what we are using, mycophenolate, tocilizumab, rituximab. In our patients, none of them were on tocilizumab, but nintedanib was there, rituximab, and all the other medication. Azathioprine was utilized, but more in the old cohort than our new cohort. So what are our limitations and consideration from our study? This is a retrospective study. Was not designed to talk about prevalence. We selected a cohort of patients with HRCT to talk about ILD pattern. So this is really a significant limitation. In addition, the retrospective design, sometimes you don't have any complete data. And the delay in the HRCT, because we said there was 6.9 years of average mean delay in obtaining the HRCT after diagnosis. So this is all can limit generalization of such results. So definitely future research is needed as prospective to collect data about management for those patients, and multi-center definitely to tell more about our country and of course the Middle East and the MENA region. So the conclusions from our research: female predominated scleroderma. ILD is common, 60% of our patients, and anti-SCL70, diffuse form, pulmonary arterial hypertension, DLCO drop, all of these are key predictors of the occurrence of interstitial lung disease. And I would like to thank all the collaborators on this research, and thank you very much for your attention.
Thank you, Dr. Fatima, for this excellent talk, very well presented and very clear.